podcast, I am joined by Helen Shiels, who's the lead radiographer at Kingsbridge Private Hospital. And this is one I'm particularly excited about. I've always wanted to be a radiographer and I have had many MRIs and scans in my time, and I always watch the face of the radiographer to see did they spot maybe what was wrong, or did they recognise why I was in or not. So I suppose I'm really excited to know more about what a radiographer does. Can you tell me what your role is and what you do on a daily basis?
Okay. So there's two types of radiographers, and all of the radiographers in Kingsbridge are diagnostic, which means that we are there to diagnose the patient. Obviously, the other side is therapeutic. The radiographers who maybe work down the cancer centre who are there to treat cancer. So there's two different types.
Okay.
All of the radiographers in Kingsbridge are diagnostic. So obviously it's a professional, you do a degree, and a lot of us in Kingsbridge have went on and done further studies into CT or MRI or education, some further postgraduate imaging. So on a daily basis we could be doing plain x-rays, so if you come in for an x-ray of your back or any other body part, CT, so computer tomography scanning, again it's used for spinal, MRI, big one that you've had yourself,
yes, and
then theatre imaging and the injection suite. So if you have a spinal injection, it's real-time x-ray, it's called fluoroscopy, so we're guiding the surgeon where to put the needle.
Okay.
In theatre then the radiographer is needed sometimes a little bit in theatre, or sometimes like the complex surgical cases the whole way through theatre.
Okay.
So we're essentially the eyes of the surgeon.
Yes.
So do we know what's wrong with you most of the time? Yes, we do.
Yeah.
And do we tell you? No.
No.
Because we're not trained to diagnose. That's the radiologist who does that for
Yes.
us, hand in hand with us.
So very much a mix then each day of actually carrying out the imaging, different types of imaging, and we'll come on to what each of those are and what
Yes.
they do, and then also involved. And I think that's the bit that I didn't appreciate, was that you are involved very actively in surgical procedures, and I had my hand held throughout my injection, and I guess it's a new appreciation for me in terms of the kind of work you do. So you said that's called
fluoroscopy.
Fluoroscopy.
So I suppose if you want to put it more succinctly, a radiographer's job is basically to diagnose you with the least dose of radiation they need. So
Okay.
if we're in surgery, for example, with Mr. Pev, we have to reduce the dose to him and you and other staff, but give him the best diagnostic quality imaging.
Okay.
So all the time we're very aware of keeping down the radiation dose.
Yes,
So
and we'll
that's
come
what
on
we're
to that
trying
as
to
well,
do.
I suppose, in terms of the safety of the different types of scanning. So I suppose it's a good time to get on to that, the different types. So is there a sort of a sliding scale in terms of what you can see in a scan, or is it all down to what's actually happening in your body and what you need?
So it's all down to what's needed. So if you see someone who refers you for some type of imaging, so whether it's x-ray, ultrasound, CT, MRI, that referral comes through to us maybe from a GP, from a physiotherapist, or from somebody you've seen in Kingsbridge. Lead radiographers, or the more senior radiographers, our job then is to triage that and justify and think what is the best type of imaging.
Okay.
So we look, right, Avril, her physio has asked for this, is this going to show what they want to see? And sometimes they don't ask for the right modality, sometimes they ask for CT, whereas it's MRI that you need, which is where our training comes in then to say, no. And sometimes the patients ring us and say, oh, my physio has asked for a CT, and then you're trying to explain CT won't show you.
Yes.
What they want, you have to have MRI.
So it's both about what you can see, but also safety.
The safety.
As
so
well.
we're trying to keep your radiation dose down. So if we can do something in MRI, which is no radiation dose, so it's a big magnet that uses your body to see bits and pieces that it needs to of the spine, we're going to go for that modality. Or ultrasound, again, which uses sound waves to try and see something, not radiation, we're going to use that because it's a safer option. In regards of a scale of safety, so plain film x-rays now, when I first trained over 20 years ago, had higher radiation dose. Now, with obviously the advancements, are much lower dose. Next to that, radiation dose wise, would be CT, and again, Kingsbridge has just got a brand spanking new CT scanner, so the doses of it are really low now. MRI and ultrasound, no dose at all of radiation. However, CT will not show everything. For example, back injury, bulging disc, something, nerve entrapment, that's not going to show on CT very well. MRI is a modality of choice, which is why most people with spinal conditions, young sports-related injuries, come for MRI.
Okay.
Other conditions, back and neck, like osteoarthritis, little osteophytes sticking out from the spine, maybe degeneration of facet joints, other parts of the spine. Obviously, CT or plain film X-ray might show them a bit better.
Okay, so there are things that CT does show better.
CT, if you've had previous surgery, you maybe have screws in there. Okay. Post-surgery, CT will show the position of those and things like that.
All right, okay.
So there are certain pros and cons for each, but our job is to try and give you one that doesn't use radiation if we can, to give you your diagnosis.
And so I didn't realise that about MRI scanning, how safe it was. I think I had just assumed that it worked on the same basis as an X-ray. So it is entirely safe for...
Yes and no. There are contraindications to MRI, which is why you filled in the big safety list before you came to Kingsbridge.
Yes.
And when you're in there, so belts and braces.
Yeah.
Certain... we wouldn't routinely do MRI in the first trimester of pregnancy for safety.
Okay.
We wouldn't do it on somebody with a pacemaker because we don't have the facility to turn cardiac devices off. You can do it, we don't. Claustrophobia, a lot of patients who are claustrophobic won't go into a scanner. Aneurysm coils in the head and things, older ones that weren't MRI safe. So everything that comes through to the MRI radiographers, the big checklist, it has to be, have you anything in your body? And Craig and the guys over there go through that very, very finely to make sure that you are not even getting in the doors before you proceed to the scan.
And so, can you self-refer for an MRI or one of the other scans?
CT and X-ray and most ultrasound, no, because it needs to come from a consultant or I'm going to say proper, that's not the right term, referrer.
Yeah, but they need to have a reason, a
proper
medical reason. They need to have a reason
why they want it. We're governed by radiation justification. So we have to make sure that the person asking for it can ask for it and they're qualified to ask for it.
Yeah.
MRI is similar, however, physiotherapists and other health professions can ask for MRI scans. So a lot of our referrals will come through from sports medicine, physiotherapists for MRI. Plain film X-rays of other parts of the body, chiropractors and podiatrists and things can ask them. But the majority comes from GPs or consultants.
And the one thing I had wondered as well, you know, when you're in having an MRI anyway, and mine have primarily been on lower back, I think, why don't they just MRI my whole body and then just do me a bit of an MOT while I'm in? And so why is it very much focused on that one area?
Well, it's focused on the body part because they use different coils for MRI it's specialist to that body part, which picks up a signal better. So they'll have a different coil they put on your lumbar spine, a different coil they'll put in your neck, your head for the signal that they're trying to get back. So we can do full body MRIs, which we do, which, yes, may show up a problem. The problem with full body screening is you're going to pick up something that's normal, that's found as a result. So a cyst in your kidney, a lung nodule, something that then has to be followed up, which isn't life-threatening, but you're always probably going to find something else, which you didn't know you had, so it won't do you any harm, but then you're going to be following it up for years.
I'm worrying about it. I suppose that's my thing when I'm having the MRIs. I'm thinking, is there something else? Are they seeing something else? And I suppose it's to remember that it is very much focused on the area.
It is, but again, if it was something specific, so say I was doing a CT of your thoracic spine, and I happened to notice if the field was big enough that you had something in your lung or a plaque in your heart, that's going to be mentioned on the report, and we're not going to follow that up.
So that's quite reassuring. I think that's been my thing. So, is would they, if they see something else, would they tell me?
It has to be anything that is seen on the scan by a radiologist has got to be reported on.
Yeah.
Okay, so they will report on it.
That's very good. And I suppose it's the back to the safety, and you talked about radiation. I mean, what is the recommendation in terms of, you know, multiple, maybe you're layering if you go for an MRI. Well, we've established MRIs are not unsafe in that respect, but if you're having X-ray, CT and maybe going for an injection, for instance.
Well, because the dose now is so low with all the modalities, you can't actually say there's a safe limit per person. So you could come and have an X-ray of your spine, and then you'll come. So we're governed by dose reference levels per patient as a radiographer, and we have to keep within those levels. So we're looked at every year when we're audited by RQIA or medical physics, and they look at our equipment and they make sure. So when you would have had your injections, and we screen or
Yeah.
do the fluoroscopy, our levels have to be within a certain limit. If they're not, then we will say to Mr. Pev, we're going high here, and obviously but our levels are way below what they should be.
Yeah. And how do you keep yourselves safe? Because obviously I know you all wore your lead cloaks,
We were
presumably.
dosimetry, we wear a monitor.
Okay.
So it is sent away every month, and it checks our radiation levels, that they're not going above a certain level. We have a radiation protection supervisor, Kelly, and she monitors that every month when she gets a read back. So if our levels were high and we'd been in theatre and injection suite a lot, we would then pull people back and put them into MRI or ultrasound to make sure that they're in areas where there's no radiation.
Yes, but over a lifetime, so you've been doing this for 20 years, you know, is it an unsafe
It's
career
not an
at
unsafe
all?
profession, no, because we have a certain amount of CVERTs we're allowed as a classified worker a year, and we don't go above those, so we have to make sure that we are monitored. Staff, for example, when they're pregnant, are given a different badge for monitoring, and they're kept out of high-dose procedures.
Yes.
So no, and a lot of people think, oh, you're a radiographer, you work with radiation, you can't have children, you're going to be barren, and no.
Oh, okay, well that's good. It's good,
It's
reassuring.
a perfectly safe profession.
Yes.
I've been doing it for almost 25 years.
Very good.
So.
And you talked about you've done a lot of research. So tell me the kinds of things, because I think maybe just assume you do your 9-to-5 job, but you've been really active in research as well.
I started off as a radiographer in the trust, went to Australia for a year, then came back and went into Jordan trying to teach the course for 10 years. So for the latter part of that, I was the course director for radiography. So I trained almost all of the radiographers I work with, which is a bit strange.
Very good.
Including my boss, which is even stranger. So then one of my childhood friends is an anaesthetist in Italy, in Bologna. So he does pain management with spine and other parts of the body. So we decided then he needed somebody who could translate from his bad English, because he's Italian speaking. So he would translate into English, and then I would help him with his research, and we published 26 articles. That's so amazing. We look at pain management. So in Italy they do a lot of the injections of the back using ultrasound, whereas here we tend to use more fluoroscopy screening. Yeah. So we do a lot of comparison with those. So I got into that, and
it's very interesting to have it run alongside.
Yeah. So then when Nikolai Pev does a lot of minimally invasive surgery, I'm sure he spoke about in Kingsbridge.
Yes.
So when he started doing that, I got very interested in how we could make it better for the patient. So how we could keep the radiation dose down, how we could even the patient. So I did questionnaires with them before the procedure and 6 weeks afterwards to see their pain scale before and their pain scale after.
Yes.
And the results of that were very promising, in that
great.
they had a great reduction in pain after, and then after 6 months, which was good. So we've done over 50 of those procedures in Kingsbridge.
Brilliant.
So,
it's very reassuring talking to you, and I think I'm hoping that people who are watching and listening also feel the same, because I think we have maybe that old-fashioned fear of x-rays and everyone having to leave the room every time an x-ray was taken. So it's really reassuring to know that firstly the patient safety is put first, and that it's such low levels of radiation, and that also that the staff aren't at risk at all.
No, not at all. So when we're in theatre, it's only the staff who need to be in there are in there. If they don't need to be in there, they're out. We wear lead coats. As well. You've probably seen they're heavy.
I've seen that, yeah. No.
So, and where possible, we stay as far away from the patient as we can, because obviously the source of radiation is, you probably notice a big machine in over you.
Yes.
So that's the X-ray tube where the dose is coming from. Yeah. So even the surgeon himself, where possible, would stand back when he can when we're taking the X-ray. Yeah. So it's all, but even with scanning, it's always the risk-benefit. So you need to see it, but you're trying to keep the radiation dose down.
And I think that's I suppose it's a nice positive way to finish the conversation, is that peace of mind that it gives. I'm sure you've seen really amazing examples of where, someone's been a life-changing cure. So what kinds of patients do you typically see the most?
A wide range of people. So obviously young sports people who have put a lot of strain on their backs over the years, doing maybe martial arts or some type of activity that we're not used to doing over and over and over again. It's not normal to do that every day. Women our age who have either had jobs where they've been lifting a lot of their lives, or nursing, things like that, maybe before manual handling training came in, when they were lifting patients or lifting things. Or women in general are very bad at lifting properly, so whether it's a baby, carrying babies, all day incorrectly, bending over. I know years ago my sister hurt her back and couldn't understand why. Every morning her little one was coming in and she was leaning over to put them into the bed. So she was doing that all the time.
Yes.
Some type of repetitive housework, women, up and down, incorrect posture, just, you know.
And bending incorrectly, which is something I was doing wrong.
Bending incorrectly, not bending their knees, even just the way you're trained when you learn manual handling to bend and lift up a box. Women don't do that. We're always running around, we're washing our hair over the bath, we're washing the bath, we're scrubbing the floor, we're doing whatever very, very incorrectly.
Yes, and it's that repetitive thing. It's the thing you do 1,000 times.
And then, again, the older patients who have degenerative changes in their back with arthritis and things like that. But a lot of times where you end up having a bulging disc or something in your back, it's just maybe you've done something really, really silly, and that it can just be bending to put your shoes on incorrectly, or lifting a pot in the garden and you've just been at that full extension and you've lifted something heavy, and that's just enough to bulge the disc out the back, which is then pressing on the nerves and giving you pain down the leg into your foot.
And I think it's fair to say, I know from the messages I'm getting that they're mainly from women, obviously, but I notice how many women are in pain on a daily basis and don't really do anything about it. They kind of push through and keep doing probably the wrong things, like the lifting and the bending incorrectly. And I guess then that's maybe why they would present. I mean, would you have people coming in who wouldn't even be able to stand or sit?
Oh, they come in, so CT and MRI suite are together, and there's sofas like this. You always know the patients for MRI because they're lying down. They're lying because they can't sit, or when they go to get the lift up to our first floor, they don't take the stairs, they take the lift. So you know the people who are in pain and the people who aren't. And I think a lot of physiotherapists now, when young people go and see them, they're very reluctant to treat until they have a baseline MRI to see the state of the patient's back first. So, I mean, for the sake of £270 for sport rate MRI, they come in, they know exactly what's wrong with their back before that they
and
then
it gives them
can decide how to treat.
A plan to,
so they can do physio, they can have back injections if that's what's warranted, and give them, as you say, peace of mind. A lot of pain relief in a short space of time if it's successful, which enables them to go on with their daily activities pain-free, which I think when you have a bad back, you get so used to being in pain for so long that you think it's normal, and it's not normal to be in pain every day doing basic jobs. So.
And so there must be great job satisfaction then. I'm sure you've seen lots of patients present who have had their lives transformed by thanks to the imaging and then the treatment that they received beyond that.
A lot of patients will come into the injection suite, hardly fit to walk, and once they have some type of facet joint injection or nerve root injection, some of them get relief almost instantly. Some don't. The pain heightens for some for a few weeks and then decreases, but some will get it instantly, and then you see the reviews that come in afterwards. It's lovely. Maybe we're very lucky in Kingsbridge that the radiographers seem to get a lot of cards and things thanking us, so it's always nice.
Great. Well, I know what it's like to be pain-free, and I'm so grateful for it, so yes. Well, certainly a very reassuring conversation there, and a great team to go and see at Kingsbridge Private Hospital. Thank you so much for your time, Helen.
Welcome.